Hello, everyone. My name is Norah Wright. I am a chief resident in emergency medicine at Temple University Hospital in Philadelphia. I am presenting my abstract alongside Derek Isenberg and Nina Gentile, all from Temple University Hospital, on the point of care qualitative EEG in a community hospital emergency department. The background for the purposes of this study was to determine patients that may be presenting in non-convulsive status epilepticus and have a delayed diagnosis due to the difficulty in obtaining an EEG within the emergency department. As many of you may know, non-convulsive status epilepticus is a challenging diagnosis to make clinically, and conventional EEG is not typically available 24/7 in many emergency departments. Point of care EEG actually is available now to rapidly identify non-convulsive status epilepticus, but very few emergency departments are utilizing this resource at this point in time. So this study was designed to determine the feasibility and potential impact of having a point of care EEG in a community emergency department and to see how useful this was to the emergency physician. For the purpose of this study, we were very grateful to receive funding from SAEM and RAMS in order to purchase 20 disposable headbands and utilize the Cerebell Rapid Response EEG system as our point of care EEG. These devices and headbands were placed at Episcopal Hospital, a satellite hospital of Temple University Hospital, that does not have any access to EEG technicians at all and does not have any in-person neurologists available either. Episcopal Hospital has over 46,000 patient encounters each year and is still an urban setting of Philadelphia. For our study, emergency medicine faculty and residents were trained on device setup and the interpretation of the brain stethoscope function, sonification of the EEG tracing that is provided by the Cerebell system. The device was applied to patients who presented with persistent altered mental status after either witnessed seizure-like activity, a known central nervous system illness or injury, or persistent coma after resuscitation from cardiac arrest. Emergency medicine physicians were trained on the interpretation of the brain stethoscope function, and this interpretation was later compared with the on-call neurologist's interpretation of the EEG tracing, which was projected onto the online Cerebell portal via their system. For our study, as I mentioned before, we had 20 headbands and we screened patients between August of 2019 and February of 2020. By the end of the study, we were able to enroll 14 completed patients into the study. 6 of the headbands were initially applied to patients and did not make it to completion. 1 patient, the headband itself was cut during application. 4 patients woke up during the process of trying to apply the headband, and 1 patient was enrolled for a pseudo-seizure, which was not one of the indications of our study. Emergency physicians interpreted the brain stethoscope function with 93% correlation to our on-call epileptologist interpretation of the EEG tracing, which we were very pleased to see. Our physicians also reported a change in their differential diagnosis and improvement in patient care by having this information in real time. Many physicians stated that this helped them to titrate benzodiazepine doses and to search for other causes of altered mental status in patients who had a negative study but still continued to have a prolonged postictal state. The conclusion of our small feasibility study was that point of care EEG is a useful tool for identification and improvement of management of these patients in the community emergency department. And our preliminary data looks promising for physician adaptation of this device into their practice and a positive impact on patient care. We want to thank SAEM for allowing us to present this virtually, given the status of our country at the moment. And we thank you for your time.